Community Center. If you've been to our building, you've seen the size of it, you know that we've got solutions to many of your physical ailments and problems. If you haven't, stop by. We're on the corner of Avenue S and Ocean Parkway. Give us a visit, you know, give your body a workout. We've got solutions that you can get ahead of the pain. We've got solutions physically that you can manage pain, and you can also look to cure it. And Dr. Mann and David Gershkovich are both going to be speaking about that tonight, which is kind of a three-tiered approach, whichever stage in life you're facing. If you're either afraid of the pain, if you're dealing with the pain, or if you're looking to defeat the pain, all things are possible, as long as you've got a plan and as long as you put that plan into action. Without further ado, I'd like to introduce Dr. Stephen Mann, who returns to us from, I think, just a few months ago in February, where he had a very well-attended Zoom, and he was speaking about lower back pain. Tonight's lecture is going to be about upper body joint pain and the way that it affects the body. And we're going to formulate together with the help of David Gershkovich an offensive plan, not just a defensive plan where you sit on the couch and wait, but actually an offensive plan to rid your body of these pains. Dr. Mann is a pain management and sports medicine specialist who practices at Unique Pain Medicine and can be readily found in Brooklyn and Manhattan. So if pain finds you, find Dr. Mann. Dr. Mann, take it away.
All right, hello, welcome to everybody. So like David said, we're going to be talking about, you know, upper body injuries. We limited it to mainly sports type injuries. You know, there's a whole different bunch of type of injuries, you know, from the arthritic side, from, you know, more, you know, active type sports injuries. So that's pretty much going to be the primary focus of tonight's lecture, or talk rather. So it'll be how to properly identify, treat, prevent common sports related injuries. Like David said, some helpful at-home stretches and exercises, and really when to seek medical advice. So a little bit about me. I went to, you know, medical school at St. George's University, did an internship at Montefiore Medical Center. I did my residency in physical medicine and rehabilitation, or physiatry at Downstate, and then I did a interventional spine and sports fellowship at Unique Pain Medicine, where I'm currently practicing. Nothing to disclose. So I like to start with this slide always, just because my background in physiatry, it's a pretty, you know, not so widely known medical specialty, I would say. You know, most people, you can see this little cartoon I put here, but you say, I'm a physiatrist, you know, people say, I don't know what that is. Are you a psychiatrist? No, I heard physicist. He's a physical therapist. He's a podiatrist I've gotten. But the bottom line is it's primarily a specialty of function. And, you know, my goal is to make sure that you're functioning properly, and to maximize quality of life. So this is just a little breakdown of the sports injuries. Like I mentioned before, we're going to focus more on these overuse type of injuries, like your, you know, tendonitis, or maybe even like, you know, stress related injuries, as opposed to some of those traumatic injuries, tears, fractures, things like that are a little out of the realm of the scope of, you know, this discussion. Those are more, you know, emergent orthopedic type of injuries. So let's dive into it. This slide has a lot going on. This is a typical joint. This is actually a knee, lower body, but everything has the same type of structure function. So you have your bone, one bone connects to the other, that makes a joint. You have a little bit of cartilage in between the bone, which reduces friction. You have your ligaments, which connect piece of bone to piece of bone, right? Gives you that structural support. You have your muscle, which is primarily responsible for movement of one bone over the other, in effect moving the joint. And you have your tendon. This tendon is what connects the muscle to the joint. So when you have an injury, you can really have an injury to any one of these structures, which is going to go ahead, and give you pain or, instability or other types of problems. So let's start with the shoulder. You have different types, right? You have a muscle, tendon, your labrum, which is kind of like that cartilage, the joint. These are just a couple of different types of injuries. The shoulder is probably the most mobile joint in the whole body. It's what we call a ball and socket joint. It's, with that mobility, you pay the price of stability. So it moves a lot. You can move it in pretty much any direction. But therefore, it's prone to these type of injuries because there's so many different muscles, tendons, ligaments that are, interplaying, that gives it that increased chance of injury. Let's move on. So the rotator cuff is probably the most common injury of the shoulder, especially in the sports world. The rotator cuff is actually made up of 4 muscles. They are primarily responsible for rotation, right? That's why you have the name rotator cuff. Internal rotation, external rotation, that's your in, out, right, type of movement. It's also responsible for some overhead movement. It's, when you put your hand behind your head, hand behind your back. The rest of the shoulder, some other muscles, the big one is like the deltoid muscle, a lot less commonly injured. The biceps, believe it or not, right, running through right onto the shoulder will give you sometimes shoulder pain as well. But I would say most of the time, it's really that rotator cuff where people have the issue, especially chronically over time. So these are the 3 types of, injuries. You can either have a tear, more traumatic, sometimes happens with age, arthritis, or even like if, when the bone starts to break down a little bit, you get these sharp edges, it can tear. Tendinitis, tendinosis are kind of on the same spectrum. That's more your overuse. That's when the tendon itself, right, where the muscle connects to the bone, gets a little inflamed. You're going to have pain with rotation of the shoulder. You're going to have pain with overhead movement. You're going to have pain, believe it or not, just by lying on the side. So if you tell me, if you come into the office, you say, hey, I have a lot of shoulder pain. I feel it, the most when I'm in bed, when I'm trying to sleep, when I'm lying on my left side, that's a pretty good sign that there's something going on in the rotator cuff. So how do we treat this? So the first step treatment is, physical therapy, activity modification, and anti-inflammatory medications. Those are probably the 3 big ones right there. Physical therapy, stretching, strengthening of the muscles that are either affected or not affected, even if you don't know what it is, even if you just say my shoulder hurts, and there's no crazy red flag signs like, inability to move it, or, it's very swollen, or, the shoulder just popped out of place or something like that. Almost anybody would benefit from a course of, strengthening and stretching of the shoulder. Activity modification, so avoid anything that hurts is a pretty simple way to say it. If you injured it from, throwing a baseball a lot, give it a rest for a little bit. If your job requires you to do a lot of activities, overhead, if you're moving boxes, something like that, avoid that. Anti-inflammatory medications work really well for this. That's your Motrin, Advil, Aleve, ibuprofen, naproxen. The next step in the treatment protocol is injections. So this is assuming the top 3 didn't work. Can do something like a cortisone shot or platelet-rich plasma, PRP. This is, a little more regenerative. I'm going to get more to the rest of these in a little bit. Is David here yet? David's in. If we could pass it over to David, he was going to show us a couple of things on the physical therapy spectrum.
David, are you on?
Hi,
So
can everybody hear me?
Yes.
Can you guys hear me okay?
Yeah, thank
Hi.
you so much.
Perfect. It's nice to see everybody. Thanks so much for having me. Hope everybody's doing well. So just a little bit about myself. My name is David Berkovich. I am a therapist for the last years. I opened up my own clinic about 5 years ago. We're called Riser Physical Medicine. We have 3 locations in Manhattan right now. And I am going to kind of fill in the gaps on some of the physical therapy interventions and try to tie up with what Dr. Mann was saying, specifically to the shoulder. So a couple of things about shoulder rehab in general without getting too sciencey. The first is I want everybody to understand that effective shoulder rehab really starts with the shoulder blades, okay? There's no such thing as quality shoulder rehab, whether it's a labral tear or rotator cuff tear, as Dr. Mann went through, without looking at the shoulder blades and kind of what they're doing. So we always want to consider shoulder blade strength, shoulder blade mobility before we even start getting too deep into the actual shoulder joint. So a couple of things to think about for general shoulder blade rehab. And again, physical therapy for various conditions of the shoulder will change based on how much pain you're in, how strong you are. But on a very basic sense, if we have this idea that I'm going to get my shoulder dealt with, then we need to start with the shoulder blade. So on a basic level, hope you guys can see. Can everybody see the back of my shoulders? Okay, so we want to be able to squeeze our shoulder blades down and back. Okay, shoulder blade squeezes down and back. That's the basic form. If we can get our shoulder blades to actually squeeze down and back, then we can set the stage for better shoulder mobility. Otherwise, when you have a shoulder issue, what ends up happening is if your shoulder blades aren't working, when you lift your arm, you start to see this compensatory kind of lift in the shoulders. Are you guys able to see me okay?
Yeah, it looks great, Dave.
Or no?
David, looks
Okay.
great.
So again, if we're without shoulder blade stability, then our shoulder compensates. We start to look like this. So Dr. Mann will probably attest to this. He's seen people come into his office with shoulder pathology, and they ask them to lift their arm, and their shoulder kind of lifts up like this. We know right away that there's shoulder blade deficiency. So if you're out there and when you lift your arms, it looks like this, you definitely want to start considering shoulder blade stabilization. Also in physical therapy, we tend to get into these TheraBands. Everyone has probably seen these at some point if they've ever done physical therapy or if they've been to any gyms. And pretty basic, we have a shoulder band pull apart where we just kind of pull the shoulder blade and sort of squeeze the shoulder blades like so. I'll give you kind of some different views here and slow return. So pretty basic shoulder blade exercise. We can pull it this way and we can manipulate our hold. We can hold like this, we can hold like this, we can hold like this. And every time we change the angle, we essentially are working a different part of the shoulder blade series. So that's the first concept I want everyone to kind of take with them related to the shoulder blade and shoulder health. The second is basic range of motion clearance. So if you're considering the fact that you might need some care for your shoulders, and you go to a mirror and you kind of raise your arms up in the air and you notice, well, my left arm goes like this and my right arm goes this high, that could be a problem. So then you have to sit back and say, okay, well, this arm's not moving all the way. You know, what can I essentially do about this? So we utilize something called wand exercises. Let me grab my wand for a second. And you can actually help your own shoulder raise up. So I'm using this stick here to kind of help my shoulder self-mobilize into different directions. All right. So these are the types of assistive mobility drills one might want to do to kind of prepare their shoulder for movement, or if they're in rehab or if they have pain. You can use this stick to actually help kind of push the shoulder into different ranges of motion. Dr. Mann went into a little bit of the kinesiology of the shoulder, but in a basic sense, the shoulder is a very mobile joint. And when there is a lot of mobility in a joint, the risk of injury is very high, okay? So that being said, it's important that you can self-evaluate and self-clear whether or not you have range this way, whether or not you have range here, and definitely behind the back. These are very important motions that need to be cleared to be pain-free, especially if you're considering doing self-shoulder type work. Lastly, I want to talk about shoulder flexibility because that's really important. Shoulder flexibility. Flexibility, we're talking more about muscle length, okay? And a lot of times with shoulder pathology, we focus on lengthening this posterior capsule of the shoulder. So you've probably seen a lot of people do this stretch. It's a popular stretch. It's a cross-body stretch, but I think of it as a stretch to stretch out these tissues. But here's where most people get it wrong. They pull their shoulder all the way over and they're not getting anywhere. So I want to tie it all back. The shoulder blade has to sit back and down. The shoulder then comes across, and only then are you actually presenting with an efficient stretch of these tissues here. Because if these tissues here start to get stiff and tight, that's when you start to lack range into flexion, into this motion, abduction, and definitely if you're an overhead athlete, if you like to play tennis, throw, or volleyball, these tissues here can get pretty stuck and bound down. That's my shoulder conceptual physical therapy presentation for you guys.
Excellent.
Now I guess I'll pass it back to, yeah, my pleasure.
Yeah, thank you very much. We're going to be providing the information for both presenters. Certainly worth the conversation after the fact. If you think you might be doing an activity, even pain-free right now, that you think, like David mentioned, that you might run into a system eventually, whether it's due to overuse or underuse, a conversation is definitely worth starting with either of these two professionals, and that information will be provided at the end of the lecture. Thanks, guys. Dr. Mann?
Okay, that was excellent. Okay, so I have a little bit here. This is just, an example of, how to diagnose any shoulder issues. This is a picture of an MRI showing, you can see if this is your rotator cuff, this black spot right here is just a little tear inside. And the same thing can actually be seen on ultrasound. So a lot of people come to me and tell me, I need an MRI. Maybe you do, maybe you don't. An MRI is not always the first thing I would do to go, diagnose a shoulder issue. A lot of times it can be seen on an ultrasound. A lot of times physical exam is the way to go. So it really depends on the clinical scenario. Next slide. And then injections, right? We briefly talked about injections. Injections are very good if you have pain, not responsive to therapy, or pain so severe that you're not able to even perform therapy. What an injection does is it reduces a lot of the inflammation. That's how the steroids work. We do them generally under ultrasound, sometimes even under fluoroscopy, which is like an X-ray. Depending on the various sites in the shoulder where the issue is, such as the rotator cuff or even the biceps tendon or in the joint itself, the steroid can work to decrease pain and inflammation. So this is another type of shoulder injury. David mentioned this briefly. This is a labrum tear. I'm not going to get too much into it. It's a similar type of injury. The labrum is sort of like a lining on the shoulder where, various type of movements can cause pain, can also contribute to, some shoulder instability in the long run. It's managed for the most part the way the rotator cuff tear is managed. The other one I included because a lot of people asked me in the past about like shoulder dislocations. This is another sports injury. This is the AC joint, but the glenohumeral joint can be dislocated as well. This is something, if this happens to you, you're playing sports, you feel, right, you see that this is what we call tenting of the shoulder, or the shoulder, pops out of place. this is something, go to the emergency room right away. Go see an orthopedic surgeon. Don't come see me if you have this. Eventually, if this continues to cause pain, then there are some things that we can do, but this is where we consider sort of your emergencies. So let's move on to the next joint. The next joint would be the elbow. The elbow, not too much pathology going on in the elbow compared to the shoulder. It's a lot more stable of a joint. The two big guys are going to be your tennis elbow, which is sort of the outer elbow region, or the top of the elbow as you want to look at it, the lateral portion, or golfer's elbow, which is pretty much the opposite. So if this is your elbow, this is the outside, these are your extensor muscles. So if you put your hand like this and you lift your arm, right, you're extending your hand. And if you even just touch up here, you can feel your muscles moving. Golfers, right, same thing, opposite side, just bring the wrist in and you feel those muscles clenching. This is going to cause pain mainly in this area. It can shoot down the forearm as well. Typically will not go into the hand or the fingers. You typically won't have other symptoms such as numbness or tingling. In that event, you would think more of a nerve type injury. It can cause difficulty to shake hands, grip an object, turn a doorknob, hold a coffee cup. Stiffness, weakness, again, the numbness, tingling, rarely you can have a nerve entrapment in this area. So how do we treat this? It's pretty much the same protocol as the shoulder. This is going to be a recurring theme for all the joints. Physical therapy, activity modification, right? You can get a brace. If you play a lot of tennis, you can build up the racket to reduce some of the stress on the elbow. You lower the tension of the strings because the softer the tennis racket is, the less pressure it's putting through the arm. Anti-inflammatory medications are very good for this, as mentioned before. Injections. So this is something that steroid doesn't really respond to. I like to do some regenerative type treatment. Again, the PRP is something we'll discuss at the end of the lecture. And surgery, again, last resort. So David will again take it away for our physical therapy portion.
All right. Can you guys hear me okay? Good. All right. So as Dr. Mann said, the elbow and the wrist, heavily connected. You can't really think about treating any elbow pathology without thinking about the wrist, because these muscles that start here and essentially here, okay? Now, when we talk about focusing specifically on tennis elbow and golfer's elbow, we're talking about various muscles and tendons that cross the lateral side or the outside, and some that cross on the inside. So right off the bat, when you come in for physical therapy to get treated for these, we do an assessment on muscle length. So how stiff, how taut, how stressed are these tendons and soft tissue here and here. So for that, we utilize different soft tissue techniques, myofascial release work, as well as different types of modalities, ultrasound, stim, etc. But if we're thinking specifically about lengthening this tissue, we're going to talk about doing a stretch that looks kind of like this. You guys are welcome to do this with me if you feel like you need some of this. So we drop the wrist down, we kind of pull the hands down this way, and we want to get our pinkies toward the elbow. So hopefully you can kind of see what I'm doing. And what I'm trying to do here is I'm trying to lengthen these muscles here. These are the ones that are most involved with tennis elbow. For golfer's elbow, we're going the opposite way. So instead of holding our wrist like this, we're going to turn our hand this way, and we're going to wrist stretch this way. We're going to try to stretch the tissue that lives more on the inside of the elbow. And you can even give it that kung fu twist where the thumbs go outside toward the elbow. So, on a simple level, it's this way and this way. On a little bit more of an advanced kind of, PT snaz level, it's down and then pulling the pinky toward the pinky side for lateral epicondylitis or tennis elbow. And then for the flexor group or the golfer's elbow side, it's this way and then pulling toward the thumb side. So you'd be surprised actually that little like rotation at the wrist actually does make a significant difference when you're trying to elongate these various tissues. So that's the first physical therapy concept, the basic stretches. Second basic physical therapy concept is the strengthening elements, okay? We do find often that pretty much anybody that comes in with an injury to a joint line is going to typically present with strength deficits or weakness. It's very rare that somebody comes in, has an abundance of pain, and has like really strong muscles. So right away, we've got to cultivate sort of some basic active exercise work to strengthen these stress tissues. So again, we can break it back to the basic TheraBand. Again, why the TheraBand? It's easy, it's lightweight, it fits in your pocket. You can take it with you wherever you want. And then all you got to do is you pull on one end and you can kind of create wrist extension from here. If you want to get a little more effective with it, you can kind of drop the elbow down this way and kind of lift up going this way. Similarly, we can do the same thing going into wrist flexion. And we can also drop from here and go into wrist flexion. There's just one more component though about the elbow that I think needs to be mentioned. And that's obviously this motion of pronation and supination. So we do rehab going into these motions as well in various ways. So it's important that when you are getting dealt with from a physical therapy standpoint, that whoever's looking at you, whoever's assessing you, is taking into consideration the various mechanics of the elbow, the relationship of the wrist to the elbow. And then just to tie it back to the shoulder, it's really important that you get looked at the entire upper extremity chain really needs to be looked at. We really need to focus on what's happening, not just at the wrist, not just at the elbow, but the shoulder, but the neck, but the shoulder blade, and how everything kind of works together. Because we typically don't move in individual sequencing, right? We move in big motions. Motions happen through an entirety of range. So it's really, really essential that we're not just thinking, oh, okay, my pain is here, therefore everything I'm dealing with is here. See, the pain is here, but I'm already focusing on this wrist. I'm already focusing on the shoulder. And I think these are the important concepts. So just to kind of tie it all up, basic stretches for tennis elbow, basic stretch for golfer's elbow, basic training methods for wrist extension, basic strengthening for wrist flexion, and then not forgetting about pronation, supination, and its various forms there. And I think that's pretty much all I got for the lateral and medial elbow issues, Dr. Mand.
Okay.
So I'm happy to send it back to you, Doctor.
Everyone can hear me? All right. So
yes.
that was great. Yeah, that was good. Again, I haven't been, doing the pinky twist myself. So that's something I'm going to incorporate. Okay. So yeah, I'm just going to touch. We had a brief question. Can you see nerve damage from an MRI? I'm gonna be talking about some nerve studies in a little bit as well. That will help us determine nerve damage. Short answer, MRI is pretty good for all types of soft tissue, nerves, injuries on that spectrum. So you can, but it depends. It's very situational dependent. So let's get back to the elbow. So in addition to physical therapy, one of the other things I mentioned was a brace. This is called a Counterforce Brace. Basically what it does is, if you see here, right where the tendon is inflamed or damaged or even partially torn, whatever's going on there, what this does by applying the pressure in the middle or beginning of the forearm, you're in effect cutting out the tendon, allowing you to perform a lot of these activities, pain-free. Same thing applies on the inside for the golfer's elbow. Okay, let's move on to the wrist, the hand. So common types of injuries, you can sprain the wrist. This happens, in sports all the time. You can fracture it. It's a pretty nasty injury. Is generally, we call these your fall on outstretched hand type injuries. So this is, when they tell you not to land, not to catch your hand, right? Fall on your butt. Fingers, jams, dislocations, not really the scope of what we're talking about here. But carpal tunnel is a pretty significant type of, ailment that people have. And that's the one I'm probably going to focus on the most here. So carpal tunnel syndrome, it's called a syndrome in the sense that there's multiple different types of symptoms and ways of presentation, but it's all kind of caused by this area right here, which is the carpal tunnel. If you can see, this is the wrist. These are the bones of your wrist right here. As soon as you pass the forearm, you get to these bones sort of, and you can even feel them right in the palm. You have all the tendons that are coming from the inside of your wrist. They all pass through this narrow little area called the carpal tunnel. And you can see they all fit nicely right underneath this ligament right here. It's called the transverse carpal ligament. The problem is that you also have a nerve that runs with them. This is called the median nerve. This is the primary nerve of the hand, responsible for sensation and movement. It supplies a couple different muscles. When this nerve gets trapped or pinched or, for any reason, irritated under the carpal tunnel, you're going to have symptoms in the distribution that this nerve supplies. So as you can see, it supplies the thumb, the first finger, the second finger, the third finger, and even actually half of this finger.
Dr. Mann, quick question. I'm just going to have you, if you can, stop the video, your video, and maybe turn it back on, because for some reason my webcam is flashing David. Can you just quickly flash? Don't exit your screen, but just can you stop your video, maybe turn it back on? Maybe that'll trigger it. I think your video stream needs some physical therapy.
Is it better?
He's still on. I can see your screen. I'm not sure if I'm unique in this issue, but the small web thumbnail is actually just David in his office. Sorry to interrupt.
Yeah, let me. Oh, I see. I spotlighted him. Let me see if this will fix it. How about now?
There you go. Good. Thank you.
Good.
Yep.
Okay.
Thanks.
Okay. So yeah, I did a bunch of demonstration with my hands. Basically just describing how the carpal tunnel sits right here in the hand. These tendons come on through along with the nerve that passes through right here. This area gets squeezed, pinched, trapped, whatever you want to call it. And your symptoms are going to come down the hand into the thumb, index, middle, and half of the ring finger usually. You get pain, you can get numbness. Over time, you can get weakness in the hand. This is when patient comes to me and says, I'm dropping objects. I can't hold a doorknob. Just any type of squeezing in the hand, you do think this type of injury. Muscle wasting, this is typically something you're really not going to see right away. This is going to happen after years and years and years. But actually the muscles that are supplied by those same nerves will start to atrophy or lose muscle mass. So this is the nerve test that I was talking about. This is called a nerve conduction study. or an EMG, electromyography. This is used for any type of nerve injury or to assess any type of nerve issue. This is what we use generally to make the diagnosis of carpal tunnel. It can be used for, a pinched nerve in the neck, in the elbow, in the back, right? Your sciatica type pinched nerves, any type of, nerve damage. People have some diabetes or any other type of neuropathy. Basically what it involves is a couple of electrical shocks or, stimulations along the area where the nerve passes through the skin. And that would be measured out on our screen, and we would be able to determine severity of the carpal tunnel. The general way to treat this mild carpal tunnel as determined by, EMG criteria, we would probably give you a brace, a little splint, you wear it at night. Moderate, that's when you start to think a lot of pain, a lot of numbness, reduce some of that swelling. That's where the steroids kick in. Severe, this is when I would refer somebody to get a carpal tunnel release surgery. Treatment. So occupational therapy, physical therapy, the OTs generally deal with the hands as far as I'm aware. Braces, splint at night, as I mentioned. I think I have a picture of that on maybe the next slide. That's your brace. Activity modification, same thing. If you're typing all day, if you're, use a computer mouse, your hand is like this, right? They make special mouses that are more ergonomic. Injections, and then again, surgery, last resort. So I'm going to kick it over to David once again.
Am I back in the game? Excellent. All right, so I'm going to pick up and talk a little bit about some physical therapy concepts. Can you guys hear me okay? Yep. Okay. Some physical therapy concepts as they pertain to hand pathology and with a little special focus on some median nerve issues. So just as Dr. Mann said, when it comes to carpal tunnel, what we're really talking about here is stress on this median nerve, this guy right here. So one of the things that we really need to focus on right away, right off the bat, is de-stressing this area that's stressed. So we talk about the activity modification. So if somebody is, typing, oh, sorry, my lights just went out. There they go. There we go, we're back. So if somebody gets median nerve compression or median nerve tension, we want to unload that stress. So we can do that with some very light stretches of the wrist and hand. Again, if somebody comes in with an inflamed nerve, we're not going to go into like excessive stretching right away. We're going to focus on trying to release these areas with light soft tissue work. We are going to focus on analyzing and assessing what their hand strength is like. So at this point, I want everyone to maybe take a second and admire this muscle right here. This is called your Thenar Eminence. This is a very, very essential muscle to the overall quality and function of our hand control, okay? For somebody who's had a very chronic type of hand nerve pathology, this muscle actually starts wasting. And this muscle right here, if you haven't thought about it, gives us a lot of strength, a lot of power for gripping, for functioning, for doing housework, for doing cleaning, for doing manual work, for pretty much anything. So it's very important that we respect the functionality of this muscle group. And when we're in therapy, we do this opposition type exercise to strengthen this muscle group. And that's a very important muscle. That's one concept to think about. The next is we want to focus on the hand's ability to go through controlled motions. So we have a group of exercises called tendon glides. When we do tendon glides, and you guys are welcome to do some of these with me here, we have our hands like so, and then the next position is like this, okay? And from here, we try to actually scrape back the fingers and try to pull our knuckles in, if everybody can see that. And then from here, we close into a fist. So these are like a variation of hand exercises. So one more time, we start with the straight hand, then we go into this position. That's like the little duck, duck, quack, quack hand. Then we pull it back to our knuckles like so. And then from here, we come down into a fist. And now there's variations on this, but the reason why we go through this specific sequence is because this becomes an essential finger, hand, even wrist control, mobility, strengthening sequence. And we tend to see that patients who have been dealing with nerve-related issues, pain in the wrist and hands, lack the ability to go through this controlled, stable motion of the wrist and hand complex. And it seems easy because I've been practicing for a long time showing people, but you'd be surprised how many people have a very difficult time going through these very basic, hand control type motions. So to kind of reel it all back in a little bit, put this whole thing together, kind of where I started with shoulder, elbow, wrist, hands. Even when I am treating somebody for a wrist or a hand pathology, I am considering the strength at the wrist level. I am considering the quality of their elbow movement and what these tissues feel like. Are they bound down? Are they super taut? Are they painful to the touch? I am considering general shoulder mobility as it pertains to the motion of the extremity. And I am almost always definitely going to look at the shoulder blade and its ability to maintain stability. Because whether we like it or not, even though we want to sit around and potentially isolate all these individual problems, we have to recognize and respect the fact that our cervical spine has various nerves. These nerves innervate all these muscles of our body. And if one part of this goes awry, it can lead to a cascade of dysfunction. So when we're thinking about the hand, I'm still considering the wrist, the elbow, the shoulder blade, the neck, because the entirety of one's motion and movement is really what is going to essentially be the link behind each joint, behind each muscle, behind each ligament, and behind each area that's innervated. So that's my strong take on wrist hand nerve related pathology. And I send that back over to you, Dr. Mann.
Okay, can you guys hear me now? Are we back?
Yeah,
Awesome.
Good to go.
All righty. So like I said, this is a splint. This is a picture of an ultrasound guided injection into the carpal tunnel, as I had alluded to earlier. You can see this is the nerve right here. These are your tendons. I know it's a little tough to see, but just imagine that each one of those are a different tendon, and that would be the nerve. Fairly simple routine procedure. Takes a couple minutes. Works pretty well. Fractures. I spoke about it earlier. I'm really not going to get into this. This is, usually when you fall, outstretched hand. You're playing sports, you fall, you land on your hand, you notice immediate pain, swelling. Don't brush it off. Go get an x-ray. Better be safe than sorry. If it is really bad and you miss it, there are certain types of fractures, specifically on the thumb side of the hand, called a scaphoid fracture, where you can lose blood supply to the hand and you deal with all sorts of problems. It's called necrosis. Basically, the bone dies. I'm not trying to scare anybody, but that would be considered, on the orthopedic realm. So let's just go back and recap a little bit of everything. Treatment and prevention. So the number one thing is fix your bad habits. If you notice that, you're overusing or, doing a lot of activity that is causing your pain, probably best to start avoiding it or doing it properly, or, finding alternatives. Stretching, very important. Therapy, I kind of put them together. Really, stretching is a part of therapy as well as exercises for strengthening. Bracing, right? Your tennis elbow brace, your night splint, pain medications, Anti-inflammatory is very, very good. Injections. We alluded to a couple of the different cortisone injections. This is more for reducing the swelling, inflammation in the area. Regenerative is a little bit newer to the game. Steroids have been around forever. We're starting to learn that, you know, multiple steroid injections probably not the best for you. 1, sure. 2, okay. You know, provided that it's spaced out a long enough time. And then surgery, again, last resort. When to seek medical attention. Severe pain, unbearable. The pain medication's not doing it for you. Pain that lasts more than 3 months, or quote unquote normal time for a tissue to heal, depending on, you know, the injury, obviously. Are your red flags? Is it, you know, swollen? The limb just blew up. Redness, right? You could have an infection. And with redness comes warmth, maybe fevers, inability to move the limb entirely. You just can't pick up your arm for whatever reason. You just can't use it. Numbness, tingling, you know, always, you know, a sign of like some type of nerve injury. Weakness, again, that kind of goes with inability to move, but a little bit less. But any generalized weakness, dropping objects, that would be something I would get checked out. So steroid injection again, I think we had the same slide earlier. I got a question about shoulder pain possibly being caused by an injection. It's not considered a typical side effect of a steroid injection. You know, we generally think of those to relieve pain. Cortisone works by decreasing the inflammation in the area. You know, a lot of times when you have a tissue injury, a tendon injury, what ends up happening is the body sends a bunch of inflammatory factors which cause swelling. The swelling is actually protective in a way because it restricts the movement of the joint. It's a natural physiological response. The problem is your body overdoes it after a while, or, you know, the tissue's healed, but for some reason there's still swelling. That's when the cortisone sort of comes into play. Cortisone itself, you know, you can get something called a cortisone flare. It's usually very, very short-lived, can cause a little bit of pain, a rare type side effect. Other than that, really, it's, you know, provided that it's done under ultrasound, that the target is properly identified, that, you know, you're in the correct location, it's not going to cause more pain. Regenerative medicine, I had to include this slide. A bunch of, you know, famous athletes. Kobe Bryant got his knee done, you know, famously. I think he flew to like Germany or something to get some stem cells. Conor McGregor got his knee done. Ronaldo got his knee. I think we have all lower body stuff here. I'm sure there's some athletes who have done upper body stuff. But, you know, the knee is obviously very, very important in sports. Platelet-rich plasma is generally a little less invasive than stem cells. And there's really a lot of research on that now, and it works pretty well. So the process of platelet-rich plasma, platelets are a natural substance that's found in your blood. Platelet-rich just means, you know, there's a lot of platelets. Plasma is basically your blood without the blood cells. So it's just the fluid in your blood. So what you do is you draw some blood, you spin it in a centrifuge, and what that does, it turns this nice red vial and it separates it by color or by weight, really. Your platelets hang out in this area. We separate them from the rest, and you put the platelets back in wherever you need to in the body. It's good because, you know, you're not injecting anything unnatural. It's, you know, part of your own body. You're just bringing some healing factors over to the area which doesn't necessarily have them or needs them at this time. Stem cells, like I said, a little bit more invasive. We tend to harvest them from the hip where there's a lot of bone marrow. There's some people out there, actually harvesting them from your own fat. They, similarly, you can inject it right on in to whichever joint. This kind of looks like a knee to me. Similar concept, promotes healing. This is a pretty drastic example. I don't know if you should expect this type of improvement, but certainly does show really good improvement at regenerating. And that's it. Any other questions? I'll open the floor. Feel free to type them, or if anybody just wants to call out, unmute themselves.
Anybody, now is your chance to get some grade A quality medical advice. Sure.
Can I ask a question?
Sure.
Hello? Can I ask a question?
Yep.
Yes, the floor is yours.
Oh, thank you so much. I have a problem with my shoulder. I developed I cannot rotate it. And I had an x-ray and they found a mass, a bone growing on the bone. I have arthritis. So the body is trying to heal itself, and it made a spur over the rotator cuff, I guess. And it's a pretty big bone spur on the shoulder. And the question is, the doctors don't want to operate on it. And the doctors suggested that I continue swimming. I really cannot swim my regular stroke. I barely go like a dog in the water, but he suggested to continuously do it because it will help the shoulder. So what do you think about that?
Okay, so I'm just gonna, restate, I guess, what you said just to make sure that I have the question clear, but basically it sounds like you have arthritis in your shoulder.
Hello?
Can you hear me?
Hello?
Can you hear me?
Did you hear my question?
Yes. Can you
Hello?
hear me?
Did you hear my question?
Esther, he did. Are you able to hear the doctor? Because he's ready with the response.
No, I did not. Oh,
Okay.
please.
Okay.
Okay, well, thank you for your question, Esther. I'm just gonna repeat your question for everybody, but it sounds like you have arthritis in the shoulder.
Yes. Yes.
You have a bone spur on the
Yes.
shoulder that
Correct.
is irritating the rotator cuff,
Yes.
which is non-operable, and you are wondering whether or not swimming is a good activity for you, correct?
Yes.
So swimming is generally a good low impact exercise. It does involve a lot of shoulder movement and strength depending on the stroke that you're swimming. But it generally can be helpful. Depending on exactly what is wrong with the rotator cuff. Obviously, I don't know if it's torn, or if there's just a little bit of tendonitis, or maybe a partial tear. Not a full thickness tear. But that sounds like a pretty good activity. I would ask David as well. What he thinks.
What can be done about the spur?
Yeah, not much, to be honest. Short of replacing the shoulder, unfortunately, not much is to be done by the spur. The question is whether or not you can live pain-free with that spur still there.
Yeah. So what I have made my decision, I take a leave 3 times. I go swimming 3 times a week. I used to swim every single day, but for a whole year we did not swim. So it atrophied, it got worse. And
Yeah.
now I must take their leave, otherwise I cannot do anything in the water. So how safe is taking their leave?
Okay. So, yeah, a leave is generally considered a pretty non-harmful pain medication. It's an anti-inflammatory pain medication. Having said that, everything, comes with its own side effects.
Right,
You know,
yeah.
I would be careful if you have any type of, heart issues before taking these medications. 3 times a day, continuously
times a
every
week.
day. 3 times a week, I apologize. So 3 times a week is generally, safe. Every other day or so, I would say that's reasonable. If it helps you get you through your day. But I would start a shoulder strengthening program at this time, seeing as it sounds like some of your muscles have atrophied.
Yes,
And David, you can speak on this more, but I would imagine that if swimming perhaps is viewed by your body as an aggressive exercise, it can only be done so often. Maybe the feet shouldn't come up in the water. You can probably do some water rehab exercises that wouldn't be as demanding or taxing in the body as a full swim. And maybe you walking in the shallow part of the pool, waving your hands back and forth at different angles. David, do you want to speak on that?
Yeah, absolutely. Can you hear me okay?
yes.
Yeah. Good to go.
Okay. So I think when it comes to swimming, obviously we have to discuss what stroke, you're using. Are you using more of a breaststroke?
The breaststroke, yes.
Okay. So when you do the breaststroke, are you feeling any pain?
Yes. Especially in the back. The backstroke, I cannot do. That's when I just go flapping my arms up and down, that's not painful, up and down. But if I try to rotate, in the back,
Right.
Backstroke, you have to move your shoulders back, and that's when I cannot do.
Right. So the general rule of thumb with activity modification as it pertains to pain is if it hurts, it's probably not ideal for your shoulder. But if you're in the pool and you're able to perform some motions that are maybe less painful, or you can perform motions that don't agitate the shoulder, those would be ideal. But if kind of coming all the way around with big rotation is giving you pain, in theory, that's just agitating the shoulder. So now on one end, right. So on one end, we want you to be in the pool because we want you to be active, and we know that's good for you, and we know it's low impact. But on the other end, we don't want you to be in the pool agitating yourself.
Right.
So the real answer is make sure that whatever stroke you're doing causes the least amount of pain. And I would recommend, if you haven't yet, starting a physical therapy regimen with somebody nearby who can assess what your limits of shoulder mobility are, where your weaknesses are, and see if maybe doing some land exercises or dry exercises can carry over to what you're trying to achieve in the pool.
Mm-hmm.
Exactly. To David's point, I mean, it seems like COVID forced your hand in taking a year off, and
Yes.
certainly time didn't fix that. So that atrophied the shoulder and kind of rendered it useless. That's not the answer. The answer is exactly what the doctor and what David spoke about, which is just modifying something where you're avoiding pain altogether, whether it's in the gym on land using like an upper body exerciser, which is like a fixed motion that can be adjusted for small circles or big ones, or in the pool with modified movements. But clearly, moving the body is the best way to go about it. Ignoring it has only led to worse.
Yes. Thank you very much. Thank you.
And we'll provide both the doctor's and David's information at the very end of this lecture.
Thank you very much. Yes, it was very helpful. Thank you.
Great.
Thank you.
Okay. We got a question in the chat saying, can tingling in the fingertips be caused by shoulder issues as well as carpal tunnel? So typically no. Shoulder pain can travel down the arm a little bit. It typically doesn't go past the elbow. What I would say is if you're having tingling in your fingertips as well as shoulder pain, I would get that evaluated by a doctor. It could be something going on in the neck. There can be a nerve that's pinched, you know, most likely in the neck, can also happen in the shoulder or anywhere else down the arm. But tingling in the finger is not common after a shoulder injury. I see another question. It says, how common are PRP injections? If not common, is it because insurance doesn't cover it, or is it risky? So there's a couple of things with that question. So one, how common are PRP injections? I mean, they're common. They're, you know, depending on the need for them, you know, whether or not you would benefit from a PRP injection, it's definitely something that most, if not all, sports medicine trained providers would offer to their patients. But you pretty much hit the nail on the head. Insurance does not cover it at this point in time. It is something that, you know, is an out-of-pocket procedure, and therefore, you know, that could be a barrier to some patients getting it. Risky? No, it's not a risky procedure. You're using your own body's platelets, so there's really no risk of infection. There's no risk of, you know, rejection. There's no risk of, you know, any other type of side effects if done properly. I think that's it for questions in the chat. Do we have anything else coming in on video?
I would offer just a piece of advice for you guys, and as professionals, certainly you know this, but you know, if you see your body or your pain levels certainly trending in a certain direction, don't wait until it's too late, where the pain becomes too much to manage. I think the best approach would be an offensive approach, right, as opposed to kind of waiting back for this thing to get worse. It's also not a bad idea to just start an exercise regimen for longevity, you know, quality of life and all that. So there's really not a reason to start or continue, you know, an exercise program. Just keep the body moving. Dr. Mann, provide us your contact information, and then David, I would love to hear from you as well.
I think I have it on the next slide, actually, if anybody is still looking at it.
Great. And I can always be reached myself. I can certainly broker that information just the same way. Great.
Okay. It's been a pleasure.
David, would you just want to, in the other one, you've got an email, it's dave@riserphysical.com, or you can reach out to me at the center. I'm David Jolowitz, and I can broker that conversation. These two are well-spoken, knowledgeable individuals and can help you get to the next step and beyond. So thank you guys for the time. Thank you to the listeners and the viewers. We will be recording it. And just like if you're looking for the information to continue the conversation, we can also replay this. We can make a link available after the show. Great. Excellent. Thank you guys so much, each and every one of you.
Thank you. Thank you.
Thank you guys. Stay tuned for the next one. On May 26th, we will have an exploratory conversation about the lower body. Hopefully you are pain-free and you just like to nerd out about knee pain. Thanks everybody.
So much. This was fantastic.
Bye-bye.
Bye.
Thank you. Have a great night.
What was
Bye,
it?
guys.
May what?
May 26th.
Okay.
I believe it's a Wednesday night, 8 p.m., May 26th. Thank you guys.
Thank you.